Hello, and thank you for joining the POCUS Certification Academy for today's POCUS Bites webinar. My name is Tiffany Claiborne, and I will be your host for today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's topic is Doppler Ultrasound Demystified, and our speaker is Kevin Rooker. Kevin Rooker has been a registered sonographer since 1984. He has been teaching sonography to physicians, sonographers, midwives, and other healthcare professionals for more than 25 years. His passion is to share his vast clinical experience with other healthcare professionals throughout the world. Let's welcome Kevin Rooker.
Thank you, Tiffany, for that kind introduction. Let me get my screen shared. There we go. So thank you, Tiffany, for that kind introduction. Good morning, good afternoon, good evening, depending on where in the world you're watching from. I must say I'm a little overwhelmed with the response to this webinar. It's great. We have participants from all over the world, so we'll have some fun with this. Want to thank you each for taking time out of your busy day to join us, and many thanks to the ARDMS and the POCUS Certification Academy for inviting me to do this presentation. Just on a personal note, real quick, I'm a big believer in POCUS. If a physician or any other healthcare professional wants to add the use of ultrasound to their practice, they should absolutely do so. Having said that, though, it's also critical that they receive the necessary training to do so. And the ARDMS POCUS Certification Academy is a great place to get started. So we have lots to cover today, so let's dive in and get going. Okay, just a quick disclosure. I am a full-time employee, BK Medical, GE Healthcare, Surgical Visualization and Guidance, as the US and Canada Product and Clinical Training Manager. And I would be remiss if I didn't remind you that October is Medical Ultrasound Awareness Month. So happy Medical Ultrasound Awareness Month. Now, today's objectives. What are we going to do? Well, we're going to look at what is Doppler. We're going to look at when and why we use Doppler in our procedures and examinations. We'll look at color Doppler versus power Doppler. Is one better than the other? We'll look at pulsed wave versus continuous wave Doppler. Again, is one better than the other? And we'll look at what's in a waveform. We'll just take a look at some waveforms and see what they're telling us, what information we can glean from those. So let's start with, what is Doppler? Well, before we can decide what is Doppler, let's look at who is Doppler. In other words, this science, this tool that we know as Doppler, was discovered by a gentleman by the name of Christian Andreas Doppler, lived in the early to mid 1800s. He's known for his principle, the Doppler effect, that the observed frequency of a sound wave depends on the relative speed of the source and the observer. He first described this in about 1842, and from what I've read, he was actually somewhat laughed at for what his presentations on the Doppler effect. It wasn't widely accepted until many years after he passed. So anyway, if you ever wonder why Doppler is always capitalized, now you know. It's because it is named after someone. And again, that was Christian Andreas Doppler. So what is the Doppler effect? You may know this, you may not. The Doppler effect, or sometimes called the Doppler shift, is the change in frequency of a sound wave in relation to an observer who is moving relative to the source. So a common example of the Doppler shift is the change in pitch you hear when an ambulance sounding its siren, as it approaches, is right in front of you and recedes away from you. Compared to the emitted frequency, the received frequency is higher as it moves closer, identical at the instant of passing by, and lower as it moves away. Now, a train is always a good example, a train whistle of the Doppler effect as well. So as that train moved toward us, was right in front of us, and then ultimately moved away from us, you could hear that change in pitch. Now, that pitch would be unchanged to the engineer driving that train because the relationship between the whistle and the engineer never changed. However, the direction, the distance of that whistle to the observer, you and I standing at the side of the train, changed, and that's why we hear that difference. So you may be familiar with Doppler and some of its non-medical uses. I don't know from personal experience, but a friend of mine once got pulled over by using the radar, and he contemplated taking that to court and arguing the Doppler effect and was this really accurate, but decided against it and just paid the fine. That was me. But you probably have seen weather radar as well. And again, they're using radar waves as opposed to sound waves, but it's the same science. It's the Doppler that tells us where the impending weather problems are, et cetera. And also another very common use is air traffic control. They use radar to bounce off of moving planes, if you will, and they can tell their direction, their speed, those types of things, just like we'll be able to do. So in medicine, we use or we bounce sound waves off of moving red blood cells. So this allows us to determine where there is blood flow, as well as the relative speed and direction of blood flow. So as you see in the example there on the left side of your screen, as that red blood cell gets closer to or moves towards the transducer, you see that frequency shift increasing. And then as it moves away from the transducer, you can see that that frequency shift begins to drop. So that's how we're going to use Doppler, is bouncing it off of red blood cells, and then we're going to display it in certain ways. So first big question, when and why do we use Doppler? Well, that kind of depends what you want to know about blood flow. In other words, Doppler can help us during diagnostic exams to evaluate blood flow in an organ, such as a kidney that you see there on the screen, or a thyroid nodule that you see there towards the bottom of the screen. We can use it during a procedure to know if there are blood vessels along the path of a needle or device. So if we're doing something like an FNA of the thyroid, and we're going to be passing a needle from the skin into that nodule, much like the one you see on the bottom, then Doppler can help us decide where there is flow, especially if there are larger vessels between the skin and where we're wanting to place our needle or device. We'll use it when we want to know if a vessel is a vein or an artery. And when we want to confirm direction of flow, such as in the portal vein. We'll look at that a couple of times as we go through the procedure, but we want to know, when looking at a liver, we want to know if the flow in the portal vein is moving into the liver or out of the liver. So we can use Doppler to help us confirm that. And when we want to know if a vessel is narrowed or stenotic, we use that quite a bit in the periphery, such as carotid ultrasound with Doppler, and peripheral vascular, looking at legs and arms and the flow in those. So when and why we use Doppler? Well, with ultrasound imaging, we have several different modes or methods available to us for Doppler, and those would include color Doppler, which is probably, especially in a POCUS type of environment, color Doppler is probably one of the more popular. Its counterpart, its cousin, power Doppler, and we'll look at each of these specifically to see what their uses are, how they work, those types of things. So there's also pulsed wave Doppler, and then we'll round it out with continuous wave Doppler. So let's look at color Doppler versus power Doppler. Color Doppler converts the blood flow movements, or that frequency shift, into an array of colors to help show the speed and direction of blood flow through a vessel. Whereas power Doppler, it's even more sensitive than color Doppler at detecting blood flow. However, it does not provide any information in regard to the speed or direction of blood flow. So which one is better? Well, it really all depends on what you want or need to know. In other words, do you want to know if there is flow or not? Then color Doppler would work. So would power Doppler. It could tell us if there's blood flow in a particular area. Is that a vessel or something else? Perhaps we're looking in a liver and we see a cystic structure. If we want to know if that is a vessel or if that is a cyst, then both color or power Doppler could help us accomplish that. What direction is the flow moving? Well, we would need to use color Doppler for that one, as power Doppler does not allow us or does not show us in what direction blood flow is moving. It just shows us where there is blood flow. How much flow? How fast is the flow moving? So if we want to know velocities in a particular area, such as a carotid artery, then we would use color Doppler as well as pulsed wave. We'll get more into that in a little bit. But we can get an idea of where the fastest flow is, even without knowing what the absolute velocities are when using color Doppler. But again, that's not possible when using power Doppler. Will this be a good path to introduce my needle or other device? Again, as we spoke of earlier, we can get a look at the direction that needle or device will be taking, and are there any large vessels in the way of that to be able to display a safe path, if you will, for that needle or device. And is there any bleeding after my procedure? I know it never bleeds after anybody's procedure, right? But on occasion, there may be some bleeding that is or has occurred. And then the color Doppler and even the power Doppler can help us see that if it's an active type of bleeding. If it's clotted off, etc., then no, because there's no movement of that blood flow. So let's look at color Doppler specifically. Color Doppler demonstrates if there is blood flow in a specific area if done correctly. And I'll talk about this several times, meaning you can easily make your display look like there's no flow within a vessel when actually there is. But you have the settings wrong. So you need to be able to understand, and we'll talk about those, but you need to be able to understand what settings you have and what you need to adjust. In other words, if I'm looking at something like a portal vein and I want to know if the flow is moving into or out of the liver at that point, well, if I turn the color on and I see no flow in that portal vein, well, I'm going to make some adjustments. I'm going to lower the scale and increase the gain. If when I do those things and there still is no flow, then I would be worried that there is no flow in that portal vein. But more than likely, if we're demonstrating no flow, it's just that we haven't set the machine correctly. So again, color gain, color scale. If we don't see the flow, we want to turn the gain down. Turn the gain up and bring the scale down to be able to show that flow. And again, power Doppler, which we'll talk about here in a moment, can help you in those low flow states. Organs, testicles, for example, that have very low flow states or prostates, we can use the power Doppler in those often to be able to pick up that slower or slow moving flow. Color Doppler will demonstrate direction, either toward or away from the transducer of blood flow. We'll talk about which colors, what they mean, etc. I'm sure most of you know on this call anyway that the color has nothing to do with arterial versus venous flow, though that's how we tend to display it. Outside of the heart, if you will, is that we're usually showing red toward and blue away, and arteries in red and veins in blue. But understand that those are settings. The color doesn't tell us what's an artery or a vein. The color tells us what direction the blood flow is moving, either toward or away from a transducer. Color Doppler also demonstrates relative or average velocities of blood flow. Again, using just the color, I can't determine how fast the blood flow is moving. I could very likely, and I'll show you examples of this, show you where the fastest flow is occurring, but then I'll need to come back with the pulse Doppler to see what that actual velocity might be. It does not, it cannot give specific velocities. Well, I got ahead of myself a little bit there, but Again, I can tell you where the fastest flow is occurring by what I see with the color Doppler display, but I cannot tell you actually how fast that might be moving, which is important when we get into diagnosis of things. Dependent on several technical factors and settings, including the angle of the color box in relation to the vessel, etc. So there are some technical, and I mentioned that earlier, the two controls I want you to keep in mind is the color gain and the color scale to be able to help you find flow if it's not there. So color Doppler, often referred to as BART, just meaning blue away and red toward. So that means the flow relative to the transducer. In other words, on the top where it says blue away, when you're looking at that flow, it's moving away from you off to the left side of the screen because of where the transducer is sitting. Now, if we took that transducer and we moved it so it's headed in the other direction, then flow in that vessel would be red because it's now moving toward the transducer. So just imagine yourself, if you will, you're sitting up on top. Let me get my laser pointer here. That you're sitting on top up here, and as you look off to this direction, the blood flow is moving towards you. That would be displayed in red, and the blood flow over here moving away from you, which would be displayed in blue. Again, keep in mind that that's operator dependent, and I'll talk about that some more in a little bit as well. But we get a color scale there on the screen. So anytime we turn the color on, the first thing I want you to do is cast your eyes onto that color indicator that shows me what colors are displaying for towards the transducer and what color it's displaying for flow away from the transducer. In this example, we're doing red toward and blue away, but understand we can reverse that, and I'll show you specifically what I mean here in just a moment. So again, looking at this scale with the reds and the kind of yellow, that's flow towards the transducer, and in the blues and into the greens is flow away from the transducer. This scale, the colors that are on the scale are completely up to you as the operator as well. You can pick straight red and straight blue, although that doesn't really tell you where you might be able to find faster flows. It'll just tell you that this flow is away and this flow is toward. So let's look at this example for a moment, because I've got one vessel and it's showing me flow in blue and in red. What the heck's going on here? And you actually see a little black line kind of right through the middle, right there. Well, if the transducer were sitting here and blood flow is moving from the right side of the screen to the left side of the screen, then this portion of it will be displayed in blue because it's moving towards, and this where it's black, it's detecting no flow, and that's where the Doppler beam's hitting that flow right at 90 degrees. And then here I see flow in red displayed away. So take a look at the scale. Remember, I said the first thing you want to do is have a look at that scale over here on the side, because what this is telling me now is that blue flow is toward the transducer and red flow is away from the transducer. And again, that's a parameter, a setting that you can do as the operator. So the orientation of the display, red toward blue away, or blue toward and red away, is at the discretion of the operator, you. So before making direction confirmations, in other words, back to the liver for a moment, before I decide whether that flow is moving into the liver or out of the liver via the portal vein, good idea to check the orientation of the display. In other words, I'm going to look up there in the corner and see what direction red is and what direction blue is. I hope that makes sense. Meaning red towards blue away, and this is blue towards red away. And there's a button somewhere on your system that says invert, and you can invert that scale if you want to. But please, please, please remember to look here when you're deciding what direction that blood flow is moving, meaning toward or away from the transducer. So I guess I like the portal vein a lot, but I think it's a good example because this is something that's critical. I want to know what direction blood flow is moving through this portal vein into the liver. Normally, flow moves into the liver via the portal vein. So when you look at this image, is the flow in the portal vein moving into or out of the liver? First thing I want to do is look up here. So this tells me that flow towards the transducer is in red. Flow away from the transducer is in blue. So I'm sitting here looking at a liver, and what I see is this flow moving this way towards the transducer, so I can confirm that blood flow is moving into the liver via the portal vein. And again, the first thing I want to look at there is my scale, and then I can confirm that that's toward the transducer, the direction that I want it to be, or should be, I guess I should say. Okay, so what is this image telling me? This is a color Doppler of a kidney. You only see flow in this area because the region of interest, that area where color is going to be displayed, is only this wide at this point in time. So it's not that there's not flow over here or over here. It's just that the region of interest for the color Doppler is limited to this area right here. Depending on what you want to know, you can open that more or even close that more. But what's this particular image telling me? I can see flow in the kidney all the way out to the periphery. So that would be a good thing, but that's in part what I'm seeing in this particular image. I can see flow both toward and away from the transducer. So I'm demonstrating both arterial and venous flow. Now the question is, which is which? Well, when I look at the scale up here, it's red toward, blue away. So what I see in red would be arterial flow moving into the kidney, and what I see in blue would be venous flow moving out of the kidney. I cannot tell exactly how fast this flow is moving. Again, I would need to use pulse wave Doppler to be able to determine that. And then I cannot tell about flow characteristics such as resistance. Is this high resistance or low resistance flow? Again, I would have to bring in the pulse wave Doppler to be able to do that. And we'll look at that as we get a little further along as well. So what's, again, using the color Doppler, what is this particular image telling me? Well, let's have a thyroid, and there's a thyroid nodule there. So what it's showing me is that there's increased flow within that thyroid nodule, increasing the risk of malignancy. Of course, it doesn't tell me that it's malignant, but it increases the risk of malignancy because of the increase in blood flow there inside that nodule. If I wanted to perform an FNA biopsy procedure on this particular lesion or nodule, it can help me plan my biopsy route to avoid vessels. Especially this big one over here, the carotid artery. You don't want to put needles in those if we can at all help it. But you could see maybe a path this direction that's a short path to be able to get to that part of the nodule, et cetera, and maybe avoid some of those vessels. So the point of this is just that it can help you see what's in your path that your needle is going to follow as it gets to something. So what's this one showing me? So normally flow should move from the right ventricle through the pulmonic valve into the pulmonary artery. I see a little bit of flow here displayed in red. So again, the first thing I want to do is come over here to my scale, and I see that that's telling me that it's red toward and blue away. So that tells me that there's actually blood flow moving from the pulmonary artery back into the right ventricle. So there's a small amount of flow moving from the pulmonary artery into the right ventricle. This is abnormal, technically, though quite common. It's kind of a standing joke sometimes in echocardiography. If you didn't see PI, you didn't look long enough. So it's very common, and this example is very clinically insignificant. But the point is, color was able to tell us that there is flow here moving in a direction that we don't expect it to be moving. So what's this image telling me? Ignore the stuff on the bottom of the screen, more about the color. I think I mentioned earlier that I can use color to show me where the fastest velocities will be. I can't tell you how fast this flow is moving. Actually, I can in this example because there's a spectrum here. I should have just cropped that off. But now I know where to put my pulsed wave Doppler sample down here because that's where I see the fastest flow. Again, from the color image, I can't tell you exactly how fast. From the spectral down here, I can, but we're getting ahead of ourselves on that one. And we'll get to that when we talk about pulsed wave Doppler. The color flow changes in a specific area tell me that this is where the highest velocities are occurring. And now you can place the pulsed wave Doppler in the sample box into that area. I can tell you back in the day, before color was available, we would actually take the pulsed wave sample and move it from wall to wall and just walk through that artery looking for increased velocities because we didn't have the advantage of the color Doppler. So I think it's made a big, big difference. So as I said before, pulsed wave Doppler is necessary to tell me what the specific velocities are in this particular example, and we'll get more on that in just a bit. So now let's talk about power Doppler, what the differences are, how we're going to use it, etc. One thing you'll notice is that there's pretty much one color here. There's not a red and a blue, but just kind of this orange to yellow type color. You don't see a baseline, if you will, because again, power can't tell us what direction blood flow is moving. It can only tell us where there is blood flow. So it's a technique that uses the amplitude, or think of that as the loudness of the Doppler signal to detect moving matter. And in our case, that's going to be blood flow. Power Doppler is independent of velocity and direction of flow. So there's no possibility of signal aliasing. Don't want to really get too deep into that today, but signal aliasing is something that occurs when we don't have enough. Think of it as there's not enough display to be able to display it properly. And that does not occur with power Doppler. So that's an advantage when we're looking at areas of very fast flow sometimes. Much more sensitive to flow than color Doppler and less technically demanding. We'll talk about it in a little bit, but the angle at which the Doppler signal intersects or hits a blood vessel will depend, or will, the lower the angle, the lower, if that angle gets towards zero, the better the Doppler signal is going to be. The higher that angle gets, especially if it gets over 60 degrees, the weaker and less accurate that signal is going to be. But none of that matters when we're using power Doppler. So if all I want to see is where there is flow, then power Doppler works wonderfully to be able to do that. It cannot display speed or direction of blood flow. So it just shows all blood flow in the same color scale, if you will. And that's because of the amplitude. Again, think of that as loudness. So the vertical axis represents frequency shift. The difference between the transmitted and the received frequency. So way back when we first started, we talked about that. We send it out and it comes back at a different frequency depending on what direction it's moving. So the brightness of the pixels over here on this part of the scale are the strength of the signal, or how loud that signal was. So when you look over here, remember as we set up here with the color Doppler, we were displaying flow moving towards us, and we were displaying flow moving away from this. But in this example, when using power Doppler, flow towards us and away from us is all displayed in the same color. So by now, you know my favorite organ, but let's look at the liver once more. So this is flow in the portal vein. Normally, flow moves into the liver via the portal vein. That's what we said before, right? So looking at this image, is the flow in the portal vein moving into or out of the liver? Trick question, because I can't tell. I can tell that there's flow in that portal vein, but unless I switch to color or add pulsed wave Doppler to this, I cannot tell you what direction that flow is moving. However, if all I wanted to know is where the vessels were in the liver, then power Doppler would be ideal. When looking at testicles for torsion, power Doppler works wonderfully to be able to display flow within that testicle so we know that it's not torsed. So it definitely has its advantages, but it also has its limitations, but so does the color. So again, it all kind of comes full circle into what is it you're trying to figure out? What is it that you want to know? Why are you using Doppler to see that? So here's an example of flow within a testicle. So at a quick glance, you could see that there is flow here. So if torsion were what we were worried about, then we pretty much ruled that out with this image. So what is this image telling me? There's abundant flow. within the testicle, and this can help to rule out testicular torsion. The same rules apply here, meaning with the scale and the gain. So if I looked at that testicle and I didn't see any flow in there, then I would want to reduce the scale and increase the gain of the power Doppler to make sure that it wasn't the settings, but that there was actually something wrong with the flow in that testicle. So what is this image telling me? And this one looks, maybe I'm horrible at colors, but maybe this one looks a little more reddish than the oranges. It really doesn't matter. That's up to you as the operator as to what you would want to, what color scale you would want to set that on. So there's increased, and again, by using the power Doppler, that's a subjective determination, but there's increased blood flow within and around this thyroid nodule, which might make us think that the potential for malignancy would be increased. And again, can help you plan a route of FNA biopsy, because we'll be able to tell where those vessels are and ideally be able to avoid them. Not even so much that it might cause some bleeding, but blood within an FNA sample is never a good idea. It'll make blood in an FNA sample will make a pathologist cranky, and we don't want cranky pathologists, do we? So what's this image telling me? Well, this happens to be a lymph node. So we see some flow in and around, and again, possibly increased. That's a subjective evaluation, but there looks like there is increased flow around and within that particular lymph node. Now, this may or may not have been visible using color flow, but this is a great example of low or slow flow detection by power Doppler. So you can imagine, just by its size and whatnot, the actual volume of blood flow moving into or out of a lymph node is not going to be volumes of flow like we might find in peripheral vascular or even cardiac imaging. So this is where power Doppler can be very helpful in detecting that. And same story again, that if we're going to do an FNA biopsy of this lymph node, this can help you plan the route to that. So what is this image telling me? Pretty, isn't it? But we have to be careful. We can't be seduced by the prettiness of color, if you will. We're trying to figure out what it's telling us. So there's a lack of flow where the green arrow is, suggesting plaque formation, which would in turn be a narrowed area. But the power Doppler really does not help me decide if this is a significant stenosis or not, because it offers no velocity information. Again, we would have to do color, but if we needed an exact number of how fast that blood flow was moving, then we would want to use the pulsed wave Doppler. Speaking of that, now we finally get there. Let's look at the differences between pulsed wave and continuous wave Doppler. Pulsed wave Doppler allows for the determination of direction and velocity measurements of blood flow at a very specific location. Okay, and I'll explain how that works here in just a moment. Continuous wave Doppler also allows for the determination of direction, but it's unable to determine the precise location that velocity measurements came from. We use it mostly in cardiac imaging, and that limitation is okay, meaning that we can't tell the precise location that it's coming from, because the waveforms will allow us, and the cardiac cycle will allow us to determine where we are. Both can help to evaluate the physiology of the waveform, whether it's high or low resistance, and I'll talk about that here a little more in just a moment as well. So, same as we said before, which is better? Well, let's look at how they work. Pulsed wave Doppler only listens to a specific area inside the vessel, referred to as the sample volume. So that's going to be this little box here. Now, I'll probably get in trouble for this, but I'll do it anyway. I think of this as spousal hearing, meaning if you're married or in a relationship, we all have spousal hearing. We hear what we want to, and we don't hear the rest. And that's what pulse wave Doppler lets us do. It lets us listen to or evaluate blood flow just within this little area right here. Now, so also I can tell you that what I'm seeing on the waveform is coming from this area right here, not down here. However, when using continuous wave, it listens to everything along the path of that sound beam. So in this particular example, I would see both arterial flow and venous flow displayed at the same time. So I couldn't tell you exactly where those fastest velocities were coming from, though they're coming from somewhere along this line. So which is better? Kind of the same answer we had before. It really all depends on what you need or want to know. Precisely where in a vessel are the highest velocities occurring? I can use pulsed wave and continuous wave. Well, I take that back. The precise part I can't use with continuous wave, but with pulsed wave I can. Is this arterial versus venous flow? Again, that'll be done on direction. What direction is the flow moving? What is the fastest flow along the path of the Doppler beam? Both will work there. In other words, I can use the continuous wave to find that fastest velocity along that path of the Doppler beam. And it'll let us do physiology measurements, such as resistive indices, pulsatility indices, all sorts of measurements we can do when we have a spectrum or a waveform to look at. So let's look first at pulsed wave Doppler. So again, the spousal hearing examination, or I guess more politically correct would be selective hearing. It only listens for blood flow information in a very specific area. The box is known as the sample volume, and that sample volume size and location is operator controlled. So, I mean, it's kind of a silly example, but it works. I just imagine whoever's inside my system has its ears plugged until it gets to a certain time, then it opens, it listens, and then it closes its ears again. And that way I only get information from where I want it. And I can be very precise about velocity measurements and those types of things. And again, remember that's operator controlled. So somewhere on your system, you'll have a control that says what the sample volume size is. In this example, it's 2 millimeters. Just depending on your equipment and whatnot, how big that will get. But then you'll get some sort of indicator there on the screen that shows you right inside that box or between those two lines is where I'm listening, where I'm getting the information from. So meaning when we look at this vessel over here, you can see the box sitting right in there or the sample volume sitting right in there. So down here does not represent what's going on here or here or here or here or here, just where that sample volume is placed. But again, that's okay because I'm using pulse wave Doppler because I want to know what speed, direction, resistive indices, etc., are occurring in that particular spot. Okay, don't want to send you over the edge. I think we made a promise that there would be no math involved in this presentation, but that's okay. Don't let this scare you. This is the Doppler equation. In other words, we're using pulse wave Doppler to tell us what the speed of the blood flow is. So the V here just represents the velocity of the blood flow. So what I need to determine that are several things. These are all constants. Everything in green down here is a constant that you don't need to worry about. Your machine already knows. What your machine or your system doesn't know, and what we need to be able to tell it, is what is the angle between the vessel long axis and the ultrasound beam. This is critical. If you get nothing else out of this presentation, I want you to get this, how important it is to determine that angle if we're doing velocities. So it would look like this. Here's the transducer sending that Doppler beam, sound beam down this way. It intersects the vessel here. So what is this angle between the vessel wall and the Doppler sound beam? And why do we care? Well, here's the error in the cosine part of this, meaning this is the angle, so the cosine of that angle. But again, you don't have to figure that out. Your machine will. But here's the error. And you can see once we get to about 60 degrees and beyond, that error gets unacceptably large. At this point, if you're trying to measure velocities and you've got an angle of incidence that's say over 80 degrees, I like to say you may as well go to the velocity dartboard and just start throwing darts at the wall and to see what the velocity is, because it will not be accurate. So I hope that's making sense. Now, you want to get into a good argument with your peers. We can argue whether everything has to be at or below 60. Some say every vessel should be done at 60. Some say, well, we can go as high as 70. There's all sorts of arguments there that I'm not going to try to flesh out today. But I will tell you that this angle of inclination, once it exceeds 60 degrees, then the error in our calculation begins to climb exponentially. So we don't want that. We want accurate velocities inside there. So we have something at our disposal called angle correction. Every system has it. That angle correction cursor, which is this straight green line here, this angle correction cursor must be parallel to the vessel walls. So in this example, it's correct. I could believe the velocities that the system are telling me. In this example, it's not correct. So I would not be able to rely on or be able to say that these particular measurements were accurate. So it must be parallel to the vessel walls. So I ask you, as you look at this one, again, you see the little box. This is the Doppler beam coming out of the transducer. This is the little box where we're listening. And then that's the angle correction. So I would ask you, does that look correct? I think it does. From my opinion, then I could believe the velocities that the waveforms are telling me are occurring. Somewhere on your system will be a readout as to what that angle correction is. In other words, this where it sits, there's no vessel or anything on here, just the box is at 60 degrees, and it tells me that up here. I can change that somewhere on my system, whether I'm changing just some systems have presets like at 0, 40, 60, 80, whatever. And then they also let you make an adjustment, a fine adjustment, if you will. If you're at 50 and you need to move it some more, then it might go, say, to 53. And again, for today's visit, I'm going to say 60 degrees or less will keep you out of trouble. What I mean by that is that your velocity measurements will be considered accurate. So they're only as accurate as the angle correction. So it looks good here, yes. And then I want to glance over here or somewhere on my display, depending on your system, to be able to confirm that that angle is 60 degrees or less. And again, that's going to be critical for the accuracy of the measurements. So back to the what is this image telling me game? Well, I can see over here that the angle correction is at about 37 degrees, and that's fine. Again, as long as it's below 60. I'm using the color. You've seen this image earlier as well, using the color to tell me where those fastest velocities might be. And then I put the pulsed wave Doppler sample volume right inside that area. And then here's the readout that I get. And those are pretty high velocities in a carotid artery. So this would tell me, or this is telling me, both what I see in the color and what I see in the waveform. This is telling me that this is a stenosis. The blood flow is moving faster in here than it should. So I'm able to measure those velocities as well as any ratios or any other indices because I'm using that spectral Doppler, or I'm sorry, that pulsed wave Doppler. I've got a good angle correction, and the angle correction looks proper when I look here on the screen. It looks like this is parallel to the vessel walls. So what I get from this particular example, I think, is accurate. So very high velocities indicating a high-grade carotid stenosis in this example. Color flow helps me decide where to place the volume, and then I can get my readings from there. I'll still move this around a little bit while I'm doing the exam just to make sure I'm finding that highest velocity. What's this image telling me? Well, the color is telling me that, see where it goes to blue here, that that's probably aliasing meaning that the scale is set too low to cause that. If I didn't want that aliasing in there, I would move that scale up, make these numbers higher, and that should avoid that. But it's also telling me what the flow is like right in this particular area. So I'm able to measure velocities, ratios, other indices like we talked about before. These are normal velocities, though color flow indicates there may be higher velocities in other locations. So this is more than likely, again, what's called aliasing, but I would want to put my sample volume within those areas just to be sure. I don't know until I actually get a pulsed wave sample out of these areas, whether it's truly aliasing or if there are higher velocities there. The auto trace function is turned on this particular one. You may or may not have that software with your system, but instead of me having to place calipers at different areas, the system will do that itself. So that's kind of a nice feature sometimes. So what is this image telling me? I think we saw this one before as well. Without the spectrum there at the bottom. But it's telling me this is a normal low resistance flow, which I would expect in a kidney. By low resistance, and we'll look at this in more detail in just a moment, meaning there's lots of flow here during diastole. What that tells me is that the arterioles here in this kidney are wide open and they are attracting blood flow. I'm able to measure a resistive index if I want to, a better parameter in the kidney than an absolute velocity. It's often very difficult for us to angle correctly within the small vessels in the kidney. So we can use other things like resistive index to decide whether that flow is normal or whether it's not. And again, the auto function is turned on. And by doing that, it will calculate whatever it is we want it to calculate, different ratios, resistive indices, those types of things. We can also do volume of flow in vessels, which we usually don't do much in kidneys, but often used for dialysis access fistulas, where we could measure, or even transplantation. There's some people working on volume flows within transplanted organs as well. Okay, so in the interest of time, let's keep moving. What is continuous wave Doppler? Continuous wave Doppler, the Doppler beam is transmitted along a line as a continuous wave and then analyzed as it returns. Continuous wave Doppler provides greater velocity ranges, so we avoid that aliasing when we're going through very high flow regions such as stenotic cardiac valves. They can get well over a meter and a half, even 2 meters sometimes, and then some of the regurgitant flow can get even higher than that. So we need continuous wave Doppler to be able to accurately measure those. If the angle of incidence is greater than 20 degrees, which is generally not in cardiac imaging, then we would want to do angle correction to get correct velocities. So when we look at continuous wave Doppler, again, there are two elements in here. One constantly talks, one constantly listens. Whereas when we do pulsed wave, it's done in pulses, just like the name says. So we're using the same element. It sends the sound out, waits for it to come back. With the continuous, it's a continuous sending of sound, and the other one is continuously receiving it. So the area where the lines cross is called the focal region. That's focal region or focus region, and that's usually where we'll get our best or strongest signal. I don't mean it to say the most accurate port, but where this, if your system has the ability to do this, that's generally where we're going to find our best signal. So what's this image telling me? Flow is moving from the pulmonary artery into the right ventricle, which is abnormal. We talked about that earlier, pulmonary insufficiency, but you can see flow normally going through the pulmonic valve here, moving away from us, and then flow moving towards us here in the regurgitant or insufficiency. Common finding known as pulmonary insufficiency. We can measure the velocity and other various calculations, which is not possible when using color flow. So let's get into waveforms. We're kind of getting towards the end here. So what's in a waveform? What is this particular, it's the one we just looked at, but what is it telling me? Well, there's a baseline right here. And what that means is flow that's moving away from the transducer is displayed beneath or below the baseline. Flow that is moving toward the transducer is displayed above the baseline. As long as my scale indication is positive this way and negative that way, again, you have an invert button on your system that allows you to do that. So the invert is rarely used in cardiac imaging because a lot of what we want to know is direction of flow. In other words, no flow should be moving up here, but it is. So that's an abnormal, again, a clinically insignificant, but a technically abnormal finding through this pulmonic valve. So again, we have the ability to invert that. So peak systolic velocity is that highest point in time that we see. Peak end diastolic velocity is not necessarily the lowest point anywhere along this part of the waveform, but it is that moment in time before blood flow begins to move away from us, towards us or faster. So what's going on? This is systole when the left ventricle is contracting, and that's why that blood flow is speeding up as it goes through there. And then when the aortic valve closes, then that blood flow will begin to slow back down. And then how much blood flow is moving here during diastole helps me decide what the resistance is. And we can measure that if we want to, a resistive index. So this is high resistance flow. This is what I would expect to see in my legs right now because I'm just standing here. I'm not running around the room. So I don't need a lot of blood flow to my legs right now. So the arterioles are very constricted to discourage flow, if you will. Now, if I go out for a 5-mile run, which I don't know if I've done since high school, then the demand for that would increase. And then I would get more of a waveform that looks like this. Now, in areas like the kidney, prostate, brain, those all want a liver, very low resistance flow. In other words, they encourage flow to come into them constantly. So a kidney will constantly have a low resistance. However, let's pick on something like the superior mesenteric artery. Right now, I haven't eaten for several hours. So if I did Doppler of my superior mesenteric artery right now, it would be a very high resistance because I don't need blood flow to my gut right now. But if I go and eat, then all of a sudden, those distant arterioles are going to dilate open to attract flow to help me digest what I just ate. So your mom taught you that a long time ago, right? During the summer, you wanted to go swimming right after lunch. And what'd she say? Don't, you'll get a cramp. Mom was right, because if there's not enough blood flow to go around, if that makes sense, meaning I can't have my legs demanding more flow, my gut demanding more flow, my kidneys demanding more flow all at once. There's not enough, so something's going to give. And as mom taught you, that's where we're going to get the cramp. My advance won't work. So some technical considerations that I want to touch on. We're almost done here, and then we'll open this up to some questions. System settings are critical. An inexperienced operator can make it look like there is no flow in a vessel when in reality there is. So in this example, the color gain is too low, the scale is too high, and here is a portal vein. But if I showed you that picture and I said, is there flow moving into the liver? You would say no. But the challenge here is that that's just the settings. So become familiar with those. So here we are, we've got a lower scale, increase the gain a little bit, and now I can see blood flow moving into the liver in that portal vein. So an hour doesn't give us time to go over all of these in detail, but I would encourage you, and I'll give you some examples in a minute, but encourage you to get more information on this. It's not difficult. It doesn't take a rocket science to be able to do this. There are just some technical considerations that most of which we've discussed, but that you'll need to keep in mind if you're going to be adding Doppler to your examination. So what are the takeaways? Well, no single modality, whether it's color, power, pulsed wave, or continuous wave, is better in all situations. Once again, it depends on what you want to know, what you're trying to prove, what you're trying to rule out, what you're trying to measure, etc. Doppler is an extremely powerful tool when used correctly. So another little caveat I want to give you is before you turn the Doppler on, I want you to know what it is that you're trying to learn before you turn it on. In other words, when we see a kidney, we don't just want to turn the color on and look at the really cool colors moving into and out of the kidney. Before you turn it on, what is it you want to know? You just want to know if there's flow there, or you're going to try and do some sort of velocity measurement, et cetera. Why are you using Doppler before you turn that on? Operator training and skills are important. I would say critical. Again, it doesn't take a rocket scientist. There are just some things that you need to know. And I would say ask your system manufacturer for any available tools they may have, any training that may be available beyond our visit today. Know that the POCUS Academy, Certification Academy, has a plethora of tools to help you learn some of this as well. So with that, I'll say thanks for attending today's webinar. You are free to contact me. I've got my work and my personal email on there. But if you have any questions that we aren't able to address today, please feel free to reach out and I'll get those answered for you. So Tiffany, I'll give it back to you.
Thank you so much, Kevin. That was a wonderful presentation, and we appreciate your time today. Doppler Demystified. And now Kevin has prepared some quiz questions for you. We are going to launch the first question, and please answer them when you get a chance. I do want to also say that this presentation will be recorded and it will be shared with you next week. So look forward to that. If you do have to drop off, because we are at the time that we stated, it will be sent to you. But the first question is up, if you can answer. All right, thank you for completing the polls. We will now begin, we will now share with you our learning score questions. This helps us to plan the next sessions and receive feedback directly from you. We have, and then we also have some audience questions that have came through to the presentation. So we will begin our Q&A portion of this webinar. Kevin, are you ready?
I'm ready.
Okay. First question. Ooh, give me one second. Ovaried Doppler, high resistant arterial flow. What does that indicate?
All right. What was the first part of that?
Ovaried Doppler,
Oh,
high
very.
resistant arterial flow. What does that indicate?
Is it maybe
Ovary.
Ovary. Okay.
Yes,
Yeah.
sorry.
No, that's okay. That's okay. So the ovary is one of those that you would expect to find low resistance flow. It's an organ that wants constant flow. It's working 24/7, unlike our gut, which only works part of the time. So I would expect a low resistance flow. So if I find a high resistance flow, there could be numerous reasons why. There could be a venous obstruction. There could be a torsed ovary. Um, Something that is stopping the blood flow from getting into the ovary. It's not as precise as being able to say this is a sign of malignancy, et cetera, but it would be a high resistance waveform into an ovary would be an indication that there's something wrong. So further testing would be helpful.
Thank you. Next question. Why demystify? What's the mystery in Doppler? Isn't it a pure science?
That's a your own question. I can't add anything to that. It's just a play on words, is all, just to make it a little more interesting. But you're right, and that's the beauty of it, is that it's physics. So unless you're a deity of some type, you don't have the ability to change it. So the rules are constant. They're the same, and that's part of what makes it. I don't know if I want to say easy, but maybe simple, is because yes, there are constant rules.
Thank you. Can we get an average velocity with power Doppler?
No. Uh, Power Doppler does not have the ability. You might get color changes. There are some companies coming out with some variations of power Doppler that let us see where there may be faster flow than other areas, but an absolute velocity, no, you cannot get with power Doppler. Any velocity, actual velocity, you're going to need a waveform, which is going to be pulsed wave or continuous wave.
Thank you. Intermittent flows. For testicular Doppler, how do we assess whether or not torsion? Should we call it a torsion?
Great question. I'll give it my best, not being a physician, but as long as there is flow to that testicle, that's a good thing. But they may be in the what would you say, the beginnings of a bigger problem. In other words, and I've seen this even in ovaries, but where with breathing or dependent changes, et cetera, it can make the flow more or less, if that makes sense. So those, I think, need to be treated as a torsion until proven otherwise. But again, if there's a stoppage in flow in a particular position or something like that, yeah, then they're on their way, I would think, to a complete torsion. So I would definitely call that abnormal and refer them to whoever needs to be referred to be able to correct that.
Thank you. What do different color shades indicate in power Doppler? What's directional power Doppler? How does it work?
I was just, that's what I was alluding to, the directional power Doppler. It's power Doppler in and of itself, again, can't tell us direction or speed. So the different colors are used to display higher returning sound, stronger signals, et cetera, which would ideally come from faster flows. So engineers get a hold of things and they make them better. I say that somewhat tongue in cheek, but they have developed a directional power Doppler by using some of the information that you would normally get, say, from color Doppler, because true power Doppler does not have that ability to show you direction, but they can add to it. In other words, power Doppler really isn't a phenomenon or something like that. It's something that we created in the ultrasound industry. So we continue to evolve and get better at it. So that is giving us the ability to use the power Doppler to even check on direction where traditionally that wasn't possible. I hope that makes sense. But it's a improvement I don't know if I want to use that word, but for lack of a better one, it's an improvement on the old power Doppler, if you will, by doing the directional. Again, they're just taking the information about the frequency shift and adding it to that, which would normally be done with color Doppler.
Thank you. I'll be asking Kevin Rooker a few more questions, but we will be wrapping up shortly. Just know that we will be sending all your questions to Kevin Rooker to answer at a later time, and you will be receiving it if we cannot get through all the questions. Next question, Kevin. What are the indications of Doppler, especially in first trimester?
Ooh, great question. And that's another one if you want to uh, create a robust conversation with your peers. Should we be using Doppler on fetuses under 14 weeks? Short answer is probably not. Uh, and one of the biggest reasons is we just don't know. I mean, I could argue this on both sides of the aisle, meaning in some instances, I think it's very powerful to help with the mother child bonding type of things, or even fathers that hear that heartbeat when we use pulse wave Doppler. However, as an industry, we always adhere to the ALARA policies, which is as low as reasonably achievable. And Doppler creates more power, if you will, so the risk of creating more heat goes up. Part of the problem here is you just don't do studies on babies to decide this. What I mean is, one baby gets no Doppler during its first trimester, and another baby gets 30 minutes a week of Doppler, and we'll see how they turn out. Obviously, we can't do that with babies, so we err on the side of caution, if that makes sense. So, as an industry, we tend to shy away from it, doing Doppler in the first trimester, but we can also do some screening with Doppler for some particular trisomies and whatnot. So it gets a little complicated. That's a great question. If you're doing it just to hear it, that's probably not a great idea. If you're doing it to determine whether there's some sort of cardiac abnormality that might lead you to believe that there's a particular trisomy going on with this fetus, then it would be helpful. So I can argue both sides of the fence on that. I hope that helps.
Thank you, Kevin. And this will be our last question. How does the size of Doppler box affect your image? If looking for small vessels, specifically MSK, is smaller box better?
Um, that doesn't have a right or wrong answer, I would say. In other words, it's really going to depend on what you want to know. So with your question, with something like MSK, where we're dealing with very little vessels, I would say yes, close that box down, because you don't want to get, conceivably, you could get signals coming from two different vessels simultaneously. And ideally, you wouldn't want that. So the smaller you can make that box, the more precise you're going to be. But also remember, the smaller the box, the more you're not going to see. I often think of a photo finish at a horse race, meaning they don't take the picture of just the very middle of the track, do they? They take the picture of the entire track. So if I want to know what's going on in a particular vessel, say like a carotid artery, I might want to open that up just to see what's going on. Now that will affect the waveform, the noise and that sort of thing in the waveform. So if I want a prettier waveform, I'm probably going to narrow that down. But the first thing I want to know is what's going on in that whole vessel. Now, the beauty is color can help me with that now, and I can see that whole vessel, and it'll help me decide where I want to put that box. But again, it's going to depend on the size of your vessel and what it is you're trying to figure out. But in your case with the MSK, I would say you want to keep that box as small as possible.
Thank you, Kevin. And like I mentioned, we got a lot of questions that came in our Q&A box, and we're sorry that we couldn't get to all the questions, but we will be submitting them to Kevin to be answered at a later time, and you will be receiving those answers via email. That wraps up our session today. Thank you so much to Kevin Rooker, our presenter. A recording of this webinar will be made available on the POCUS.org website in approximately 1 week, and you will receive a link via email. Thank you for attending today's webinar, and we look forward to seeing you on a future webinar. Take care.
Thanks, Tiffany. Thanks, everyone.
Thank you.